we will go to the next one, transcatheter treatment of pulmonary AV fistulas by Dr. Manotosh Panja, who is a very senior interventional cardiologist in India who practices in Calcutta.
I am very thankful to Dr. N. Khanna for inviting me for this prestigious conference. My talk is transcatheter fixture of pulmonary arteriovenous fistula. Regarding starting, I feel the interaction, the diagnosis of pulmonary arterial fistula, the ante-mortem diagnosis of this pulmonary arterial fistula first made by Dr. Smith and Hutton. Pulmonary arterial fistula really is a part of syndrome of hereditary telangiectasia, which was called the Osler-Weaver-Rendu syndrome, even absence of the cutaneous and mucosal manifestation. Classic clinical feature on general survey is cyanosis, polycythemia, clubbing, and presence of murmur over the chest. Diagnosis suspected because of chest X-ray, some coarse mottling on the chest, and injection of contrast media on the arm, and CT of the lungs, and ultimately right heart catheterization is to be done. Untreated pulmonary arterial fistula complicated by rupture of massive hemorrhage, cardiac decompression in heart failure, cerebral thrombosis due to polycythemia, and cerebral emboli passage from periphery through the arteriovenous fistula to the brain, and it may cause brain abscess, meningoencephalitis, impairment of cerebral function due to chronic hypoxemia may be present. Eventually, treatment of pulmonary arterial fistula, medical therapy not effective at all. Surgery, those are small size and less number of arterial fistula aneurysm, that can be, excision can be done. Arterial fistula excision is a treatment of choice for multiple bilateral, medium to small size and large size, all type of aneurysm due to pulmonary fistula can be intervention on the treatment. Here, bilateral pulmonary fistula managed by vascular plaque and coil. This is my experience. One case is going to present now. My patient came from Aizawl to me to Calcutta. 19 years old man presented the history of worsening cyanosis since birth and frequent episode of hemoptysis. Systemic examination revealed cyanosis clubbing, and cardiovascular examination essentially normal. Echo and 2D echography with a normal limit. Resting oxygen saturation was 84. In view of strong suspicion of pulmonary arterial fistula, CT pulmonary angiogram was done, showed multiple pulmonary arterial fistula in both the lungs. Among those, right lower lobe and left upper lobe fistula larger and aneurysmal dilated. In view of this significant recurrent hemoptysis, hypoxia, and pulmonary arterial fistula percutaneous closure by two large fistula was planned at beginning. Now, here you see CT angio shows on the left side huge aneurysm and from the right lower lobe and left upper lobe, and right heart catheterization by particularly the angiography shows some multiple small to medium size and large size pulmonary fistula on the shown on the right side. Now here selective cannulated by long M plus exchange wire passes through the 14F delivery sheath, and here 16 millimeter amperature type 2 vascular plug was deployed using 14F delivery sheath. Ultimately, final result closed large right lobe AV fistula that is visible on this right lower lobe of the right side. Now, similarly, 12 millimeter amperature type vascular plug was deployed using through the 12F delivery sheath on the left upper lobe vessel, which and now visualize the diploid plaque is well visualized. Final result of the first procedure after the deployment of the two large plaque, oxygen saturation improved from 84 to 98%. Post-procedure check angiography was certified with well deployed device, and two large closed atrial fistula are done by these two vascular plaques. Patient did well postoperatively. He was discharged with aspirin for 6 months. On follow-up after 11 months, patients doing well. Oxygen saturation went down to 90%. Still, we are planning for next procedure regarding the remaining medium-sized atrial fistula next stage. So after 1 year, initially 2012, we have done this first procedure. Now second procedure, after 1 year, that is 24 April 2013, we have done the diagnostic angiography here, and medium size fistula is seen, lower lobe, right lower lobe vessels, and next to left side there are some last year's diploid plaque is well visualized, and now after deployment of them, that is the 6 millimeter M plus 6 millimeter diploid right lower lobe. After that, another vascular plaque 6 millimeter diploid of the right upper lobe. So right upper lobe well visualized, diploid. Now another fistula on the mid right lobe, 2 coils diploid on the mid right lobe fistula, you see. And third procedure done after another 1 year on the July 2014. So that means altogether after 2 years, and angiography shows, and there is some large atrial fistula with aneurysm located on the left lower lobe. Then vascular plaque, the 6 millimeter diploid in left lower lobe, which is well demarcated on the left side. Now another large fistula, particularly detected on the mid zone of the left lobe, and vascular plaque 14 millimeter diploid in the left mid lobe, you see, well visualized. So altogether second stage with the both lower lobe, left lower lobe and middle lobe, 2 M plus plaques is diploid now. Therefore, take home message: pulmonary atrial fistula present to the recurrent hemoptysis, severe clogging, cyanosis, extremely rare. Vascular M plus plaque is very useful because of the bilateral and large size atrial fistula to save the life of the patient, resulting improvement of signs and symptoms, including oxygen saturation. After the 11 months of the first procedure, so oxygen again dropped to 90%. Then 2 small plaques and 2 coil was very useful. Close the medium-sized atrial fistula on the right side, resulting oxygen saturation 100% with great symptomatic improvement. Again on 2014, that means after 2 years of the first procedure, the third procedure, oxygen saturation dropped to 88% from 100%. And thereafter, deployment of 2 vascular M plus F plaque, 16 millimeter, and left lower lobe and left mid lobe respectively done, and oxygen saturation become once again 100%. Cyanosis fully disappear even after exercise. So, ladies and gentlemen, on conclusion, atrial fistula may be congenital or cirrhosis of liver with portal hypertension. My case, it is a congenital origin. Surgery is not attempted in my patient because of diffuse nature of atrial fistula with multiple small and large size AV fistula. treatment is only done by intervention, by vascular flux, altogether 6 vascular flux and 2 coil done in this patient. So resulting excellent result. Now from 2012 to about 7 years follow-up altogether now, and patient doing well and symptom improved. There is no sinus clubbing. He is doing the routine work, day-to-day activities every day. Thank you very much for patient hearing.
Thank you very much, Dr. Panja. That was a very interesting case, and I remember we did the first case together at your center in Calcutta, the first one, part of this procedure, and it's been very rewarding to actually hear that the patient is doing so well. We would come to the discussion in the end. We also have Dr. Dayasagar Rao, who has joined in, who would be talking about changing landscape in the management of pulmonary embolism. Is there Dr. Dayasagar Rao? Yeah, so I see him. Welcome, Dr. Dayasagar Rao. He had a little issue in logging in and in presenting his slides, so now we are all set. And maybe at the end of the session, we'll take all the questions together.